Palliative medicine, palliative care, is a wonderful topic to focus on this evening. It happens to be of unique value in Edinburgh, both within the National Health Service and the university, and in fact our Royal Colleges. Not everybody understands that palliative medicine is now a recognised full specialty in medicine, but its origins were in the hospice movement. And I'm looking round to see Dr. Doyle isn't in the audience. Derek Doyle may be joining us this evening, but some of you will know that St. Columba's Hospice was launched in the late 1970s by Derek Doyle, and it rapidly established itself alongside St. Christopher's Hospice in London as one of the flagship hospices in the UK. And as it happens, the UK have led the world in developing the concept of what we now almost take for granted as modern hospice medicine, which then filtered back into hospital medicine, general practice on a more wide scale, and is now as a recognised specialty. The reason the hospice was a success was people were looking for excellence in clinical management of people towards the end of life. The concept of having a peaceful setting rather than noisy hospital ward, the concept of talking with and caring for people right to the very end of their lives rather than being shunted to the end of a ward that was busy with people who were more acutely ill and so on, resonated very well with the Edinburgh community. But the important thing was the excellence that was defined by the hospice very rapidly became an outreach program nationally and internationally. We have to thank Derek Doyle a great deal for doing that. Education follows into research. You can't go on doing the same thing forever. And the University of Edinburgh and St. Columba's Hospice jointly decided a few years ago to fund a chair in palliative medicine. And our first speaker this evening is Mary Fallon, who was appointed to the first St. Columba's Hospice chair of palliative medicine. The concept, and she's going to address a specific issue of the science of medicine, which palliative medicine is just as involved in as with good bedside clinical care. And Mary Fallon is going to tell you something about the science and the applications of what we understand about the causes of pain and how to manage pain. Our principal was so impressed with the fact that the hospice wanted to join more directly with the university that he found the money for a second chair of palliative medicine. And we have Professor Scott Murray with us this evening, who's the Professor of Palliative Medicine in Primary Care. And I think I'm right in saying that we're the only university in Europe that has 2 chairs of palliative medicine. The concept of outreach has actually always been part of the Scottish mentality in education and particularly in medicine. And there is now an extremely exciting programme happening between Edinburgh and African countries who could not be more different in their needs, but also their outlook and their resources and facilities and everything else. And the second talk you'll hear from tonight is from the Deputy Director of our Global Health Academy, Dr. Elizabeth Grant. And she will tell you of some of the very, very interesting, important work that we're engaging in with Africa. Opposite ends of the spectrum, but a common theme. So enough by introduction of me. Let me hand over to Mary Fallon, who's going to tell you something about the management of pain.
Thank you very much indeed, Professor Smythe. And I think it's only fair at this point to say that it was largely due to the huge efforts of Professor Smythe that in fact we have 2 chairs of palliative medicine in Edinburgh. So what I'm going to do is not cover palliative care in a global way. As Professor Smythe said, I'm going to home in quite specifically on one of the areas that we are researching, and that's cancer pain. A lot of our research on cancer pain is also applicable to chronic non-malignant pain, but for this evening most of what I'm going to say really alludes to our cancer pain programme. I'm going to cover a little bit about how we improve pain control for everyone using the methods that we've tried and tested and we know in fact can work very well but aren't reaching everyone. And I'm then going to go on to deal with the more challenging areas of pain which we really are having to find new and better solutions for. So, improved assessment and pain relief for everyone, the challenging pains, in particular bone pain and nerve pain, and thirdly, and very importantly, it's all very well having an armamentarium and a variety of treatments that you can offer to patients, but for patients particularly who have a limited life expectancy, they don't want to be spending months trying out new treatments and finding out which treatment might work for them. What we're very much trying to do and embedded in all of our programme is to predict which treatment is best for which patient. And we see that as key to any future research. I'm not sure how well this is projecting. Yes, we can pop it down. Let's see.
Good
Do a high. Great stuff. Good thought. And some of you may recognise this, but this Eber's papyrus, in fact, dates from millennium BC. And one of the little gems it contains is this. The goddess Isis gave the juice of the poppy to Ra, the sun god, to treat his headache. And the literature is full of reference to very ancient literature of the use of the opium poppy and the effective use of the opium poppy. And when we think of pain, we always come back to thinking that really opioids, and by opioids I mean morphine and morphine-related drugs. We have newer synthetic versions these days. But on the whole, they have always remained key to pain control, and in particular cancer pain control. But of course, one of our challenges is that we want to have optimum pain relief and we want to have minimal side effects. And that has been a challenge really for many decades, ever since we started using morphine regularly and orally and then having injectable forms. We've constantly had the feedback that yes, there can be good pain relief in many patients, but there can be an unacceptable side effect profile. There can be drowsiness, a bit of dysphoria, and patients often don't like the effect. And one of the first parts of our programme was actually striving to find how we can actually deliver opioids to individual patients in an optimal way. And the first part of this work has just come to fruition and just published in the Lancet Oncology. And we now have established that in fact individuals will respond optimally to a particular opioid, and that won't necessarily be morphine. And we now, of course, can advise that we may use one of the sister drugs, hydromorphone or oxycodone or fentanyl. And this has, in fact, improved this profile for very many patients. And I think this is a very basic piece of research that we have been working on and continue to work on. And I think it has, in fact, already been improving quality of life. The second very basic bit of research is, you'll all be very aware of the WHO analgesic ladder. And way back in the 1980s, a group of experts got together and said, well, cancer pain is very poorly controlled. Why is that? And it was really because physicians in particular were not using drugs in a very systematic way. They were being somewhat chaotic. And they got together, the experts, and they said, well, look, let's develop a simple approach that uses drugs that are widely available and that are cheap and that everyone is familiar with. And this three-step ladder was developed. And if you have moderate to severe pain, then the idea is that you'll progress up to step 3 and you'll have a morphine, or now, according to our guidelines, you'll have an alternative strong opioid, if that suits you better. But we felt that now, 3 decades on, this has been very important, but in fact we've been suspicious that we can improve on it, and we can in fact deliver something on a worldwide basis that might lead to more efficient pain control. And our question is, would 2 steps be better than 3 steps? Do we need this middle step that involves codeine? And 10% of us, in fact, wouldn't be able to use codeine. We can't metabolize codeine. And we were interested in, does in fact 2 steps achieve pain control faster than the traditional 3 steps as recommended by WHO? Well, we completed a pilot study that confirmed this suspicion, and the pain control was achieved faster with 2 steps rather than 3 steps, and we also had very nice improvements in the level of pain experienced by patients. And this work is now moving on to a worldwide multi-centre study. So we've got Europe, we've also got Australia involved, and we've got Africa involved. And of course this is a very important study for Africa, where codeine paradoxically is very expensive. So this study has just started. Edinburgh's been the first centre to start. It's been led by Edinburgh, and it will take 3 years to complete, but it potentially may in fact change the complete mindset of the WHO 3-step ladder. And we're very hopeful that this will in fact lead to more efficient, to faster pain control on a worldwide basis. So a very basic piece of research, but again, important. And finally, from the basic point of view, we're all very aware, perhaps ourselves or through relatives, that being a patient isn't easy. Being in the acute setting isn't easy. Having nurses dashing round about you and sitting there, not feeling quite so comfortable, or in fact having severe pain, can be very difficult. And in our acute hospital wards, often the drugs are available to treat pain, the knowledge is available, but the systems sometimes don't bring the drugs to the patients in a timely way, in an effective way. And of course, one of the most important things with pain is to control it early and to control it effectively. And so we had an idea, and I have to be entirely honest, it wasn't the 5th vital sign, pain is the 5th vital sign, wasn't our original idea, it was an American idea, but we took this American idea and we incorporated it into the UK system. And we came up with a bedside chart that would allow the nurses to ask about pain in all cancer centres, alongside checking blood pressure, temperature and pulse. And then if the patient did have poorly controlled pain, lead to some other pertinent questions, and that was linked with appropriate management. We did some pilot work, and again it was very successful in Edinburgh, and this study is just completing. It has taken almost 5 years to do, and it's been done in 19 cancer centres throughout the UK, and we're about 20 patients short of our almost 2,000 patients recruited into the study, and it's going to be very informative and very helpful in actually helping to control and improve cancer pain management for everyone in the acute setting. And this is just the vital sign chart. It's a traffic light system, and this was the Edinburgh idea. Likewise, the management algorithms came from Edinburgh. We've already had people from other countries wanting to use it, and we've already had it very successfully replicated in Kenya, in fact. Now, these are things that the first 3 topics were really exploiting readily available drugs, simple methods of pain control, and optimizing what we can do, what we can all do. Now I'm going to talk about the more challenging pains, and in particular bone pain and nerve pain, and what we're trying to do about that. Now, you will, of course, all be very familiar with the DECA diagram and the traditional idea of the man who puts his foot in the fire, and the impulses will go up via the spinothalamic tract, and the signal in his head will tell him where the pain is. It's in his foot and how severe it is. Looking at this, probably 10 out of 10, 10 being worst pain imaginable. But life's not as easy as that. And of course, we're not hardwired. These systems are very plastic. They change all the time. And they change from the anatomical or a functional point of view. These nerves actually behave in different ways under different situations. Likewise, with the chemicals that will transmit the pain signals will increase, decrease. The balance in these can be significantly altered. And likewise, the impulses, the electrical impulses that go into the spinal cord can change in certain circumstances. Now, these set of circumstances can all change for the worse, particularly in some types of pain, particularly in nerve pain, and particularly in bone pain. And our challenge has been to work very closely with our basic science colleagues to try and understand the underlying, what we call neurobiological mechanisms of pain, and then to see how we can actually translate that into the clinic and find better ways of pain control. Now, there has been an increase in the number of drugs available to treat both nerve pain and to some extent bone pain, but much fewer for bone pain. And going back to one of my first points, there is absolutely no evidence for which drug is right for which individual patient. So with an increasing armamentarium, it can mean one simply going through an increased number of trials of a drug to try and control the pain. And obviously, in palliative care in particular, time is very precious, and this is a waste of time. Just blindly trying drugs, which we know will work for someone, but may not work for that individual. So everything I'm going to tell you now, the research program also has embedded within it a very precise assessment of our patients and their pain, where we characterize them, and then at the end of all of our studies, we can dissect out which types of characteristics respond best to which drugs. And part of this methodology is what we call using biomarkers, and we use something that's very particular called quantitative sensory testing. It's relatively quick, it's very precise, and we've actually developed and published on a modified version of this, particularly suitable for patients with cancer pain, that we've developed here in Edinburgh. And in particular, the things that are of great interest are, this rod here is 40 degrees, the warm, and the blue one, the cool, is 25 degrees. If I put them on myself, or on any of you that would be perfectly comfortable, you'd think it was cool or warm. But when we have disruption of this pathway that we've been looking at, and the underlying mechanisms are changed, the sensations with these rods, and also with certain hairs, pressures of hairs we put in the skin, can be changed quite dramatically. And the profile we get from this tells us a great deal about the underlying nervous system, what's actually happening, and what drugs then might be most suited to that particular patient. So looking first of all at bone pain, I'm going to give you just a very quick resume of what we've done here so far. Although bone is the third most common site for metastatic disease, unfortunately it is the most common cause of pain, and particularly in breast and prostate cancer, we have up to 90% of patients will have bony metastatic disease. So the tumour that's spread to bone by the terminal period. And this is very problematic. It really impacts significantly on quality of life. And what we did was we looked first of all at the best treatment we have for bone pain, and that's palliative radiotherapy. That's the gold standard. So 50% of all patients will get at least 50% pain relief with palliative radiotherapy directed to the site of bone pain. And then on top of that, we actually looked at the very precise characteristics. And we looked at the characteristics of patients who responded to palliative radiotherapy and those that didn't. And we've now done a pilot study, and we've done a larger, more definitive study. And again, these temperature changes tell us a huge amount. So if in fact you have an abnormal sensation to the cool temperature, you are 7 times more likely to get analgesia, to get pain relief from palliative radiotherapy. And this has a number of implications. And we're also using this in our work, where we're going on to look at novel treatments other than palliative radiotherapy. And this work is going to be the focus of part of a large EU grant that we're involved in this year. Similar, we're using this methodology in work with a drug called pregabalin. So I've said for nerve pain there's a number of drugs. For bone pain we've got palliative radiotherapy, but we don't have many other useful analgesics for some particular components of bone pain. So particularly pain on movement, or sometimes patients may get very spontaneous pain at rest and no warning of it. And again, we've worked with our laboratory colleagues to develop a translational project using this drug called pregabalin, with the intention of trying to control the pain on movement and the spontaneous pain at rest. And the benefits of this are obviously for those patients who don't get a response to radiotherapy, this is an option. And also adding it into radiotherapy may improve the response to radiotherapy. So we've been doing a multi-center randomized controlled trial, which I'm delighted to say has just completed 3 weeks ago. And we're currently analysing this. And again, embedded within this, we have the characteristics of those patients that respond to pregabalin versus those that don't. So we're building up a picture of which patients respond to which treatment. And this programme in bone pain is continuing in a number of different directions. Just to say briefly that from the point of view of nerve pain, one of our great problems, and this is the spinal cord, so if we remember our Descartes picture, the man with the foot, so this was his peripheral noxious stimulus, the foot going on the fire, and then the signal sent up to the spinal cord, it is computed here and transferred up to the brain. At this level in the spinal cord, with nerve pain, there are a number of problems happen, both from the point of view of the anatomy of the nerve fibres, and which change so that the function changes, and they start transmitting, instead of light touch will be transmitted into a painful sensation. So the function changes. We also get a change in neurotransmitters, and we get a change in the volleys of the impulses. And nerve pain can be very challenging, and we use a term called wind-up. And wind-up is when the simple drugs that we would actually use to dampen down this nerve pain no longer work because these chemicals have been changed, the function of the nerves have been changed, and the volleys are going in really fast. And we have to calm the whole situation down so that we can actually get a response from normal analgesia again. Now, ketamine is a very old drug. And whenever I mention it to patients, the first thing they always say is, oh yes, it's used in veterinary medicine. And of course, almost all of the drugs that we use for pain relief in palliative care can be synonymous with less favourable uses. But it is interesting, when any of these are used appropriately for pain, the effects are really quite different when used inappropriately. But this is a key analgesic in trying to dampen down this wind-up and we're very interested in evidence for its use and also understanding who will benefit from it. So again, we've got the so-called biomarkers embedded in the programme so that we can characterise the patients who respond. And we're also working in a programme to develop the daughter of ketamine. Moving on to another part of our programme, and that's looking at cannabinoids. Now, again, just like morphine, just like dimorphine, just like ketamine, cannabinoids and cannabis has, of course, been a drug that's been used for hedonistic reasons in the past. And I've now been chief investigator of 3 multi-centre randomised controlled trials looking at cannabis, and we're on to our final study before we get what we believe is probably the legal stamp to use it medicinally. It comes in a spray, and it's basically what we're using clinically is an extract of the cannabis plant that takes 2 different cannabinoids that we know, when used in this balanced way, gives the optimum balance between pain relief and side effects. And so far, we've had several hundred patients through these studies, multi-centre studies, and the side effect profile has been very favourable, very mild side effects. Patients don't get the euphoric effects that they get, but often when using it in an abuse way, but when using it in this medicinal way, where we've got this balance, we're often looking at pain relief without unwanted side effects. Clearly, no drug will work for everyone, and the group of patients where we've seen it to be of particular use is those with very challenging nerve pain. Some of our translational work also points to the fact that it may be useful in bone pain as well. Now, sticking with the plants, or perhaps more correctly a herb, and moving on to our programme with menthol. Menthol, we believe, is going to be of use in nerve pain, perhaps in bone pain, and certainly in treatment-related neuropathies. And I'll say a little bit more about that. But capsaicin is red hot chili pepper, and we do work with that, and I'm not going to chat about that this evening, but it works in the same family of receptors, but just a different subtype from menthol that works in this tryptophan-8. And menthol is a cooling agent. It gives analgesia via a cooling mechanism. And again, this is work that is translational here in Edinburgh, that came from initially the laboratory of Sue Fleetwood Walker, and I think is a very nice example of translational research. And I'll tell you a bit about that. So when you actually have an injury to a nerve, you get what's called upregulation. If you like, some receptors become more plentiful, more available. And we have identified that this group of receptors, tryptophan-8 receptors that menthol works on, are upregulated in nerve injury. And we moved quite quickly with this piece of work simply because one of the problems with what we have now is often very effective chemotherapy, but some chemotherapies, in particular the platinums, oxaliplatin, for example, can be associated with a peripheral neuropathy. So you get a sensory and a motor disturbance after the chemotherapy that can persist a year after chemotherapy in up to 35% of patients, and there is no good treatment. And I actually saw a very distressed patient who sat every night with his feet in a bucket of ice. He didn't respond to any treatment at all, and his life-prolonging chemotherapy had to be abandoned because of this very distressing chemotherapy-induced peripheral neuropathy. I had just had a very interesting conversation with my laboratory colleague about our work with this menthol and tryptophan-8, And of course we use menthol for itch, so it's available. And I applied topical menthol to this patient, and in fact he had the most dramatic improvement and was off all analgesia in 2 weeks, was walking about, threw his walking stick away, and continued with his chemotherapy. So following another couple of cases, which again were very hopeful, we progressed to a proof of concept study which showed really quite marked subjective improvements, but interestingly also more objective improvements, because when you do an open study, of course, there's always the placebo effect. So we're very hopeful about this, and in fact we're just about to embark, thanks to Wellcome, on a large randomised controlled trial looking at topical menthol in chemotherapy-induced peripheral neuropathy. And of course, that has benefits, not just in patients undergoing chemotherapy or post-chemotherapy, but also in patients with other type of nerve pain, such as directly related to the cancer. Now finally, just to say a word about, often we look after patients who appear to have very similar scans, they describe very similar pains, but they actually require very different treatments. And that's linking back with what I said initially. How do we actually decide which treatment for which patient? Because that is the Holy Grail. That's what we're trying to achieve. And I've taken out the previous slide, although I had permission from the patient's family, but it showed a gentleman golfing. And in fact, he was terminally ill and died a month after the photograph was taken. And he had a scan identical to this. This, however, is a young lady with the same scan and the same pain, but she actually required epidural analgesia. We had to put a little catheter into her back and put the drugs in that way because the pain was very challenging. It didn't respond to the drugs that our first patient responded to. And this does remain part of the Holy Grail. And in the past, this very famous lady, Dame Cicely Saunders, who's the London equivalent of Dr Derek Doyle and was based in St Christopher's, she came up with this idea of total pain. And in the past, we might have said, well, this patient perhaps is not responding to these drugs because, yes, there is definitely a very severe pain there, but maybe the patient's very anxious or depressed and maybe needs a different sort of treatment. And yes, we haven't lost the concept of total pain, but what science has actually brought us and what we can understand is some of the mechanisms behind total pain. We understand now this is the spinal cord, this is our midbrain, and this is our cortex. So we have pain coming in here, and our cortex will tell us where the pain is. So it's in the man's foot, and it's 10 out of 10. But our midbrain will actually process the input from the centres that deal with fear, anxiety, sleep deprivation, depression, and they will input into the spinal cord. And if you are sleep deprived and anxious and depressed, it will genuinely increase the pain that's processed in the spinal cord, the feedback there, and we know this through a combination of quite sophisticated studies, including functional imaging. Whereas if we have someone who is well rested, isn't anxious, isn't depressed, there can in fact be inhibition of the pain pathways. So we have this vicious cycle, and we really are coming to understand that yes, we are total, complete individuals, but there's a science behind it. And I think that's something that's actually very important, very useful. I've talked a little bit about what's happening at home, but it's very heartening to know that much of our work is also being taken elsewhere, in particular Africa, but also South America. And I think this both strengthens our research programme and also potentially increases the acceptability of results in other countries. I think, and I hope that you'll see that science is actually facilitating the central tenet of palliative medicine, and that's the art of individual care. We're no longer wanting to say, if you've got severe pain, take morphine and take it at the following dose and that's it. We're saying, if you've got severe pain, let's see you, let's examine you. What's the pain like? We think the following is the best treatment for you, and that will give you the optimum balance between analgesia and unwanted side effects. And I think we are becoming closer to the art of individual care through closer collaboration, in fact, with a number of colleagues, including basic science colleagues. And I'd like to thank very much the huge number of people that have been very helpful in the programme, and most of all, of course, our patients. Thank you very much.
Back to the thing, but Mary, thank you very much indeed. It was an absolutely super talk. Yes, I really do, I know I'm showing off the university tonight, but I really do emphasise that there are very few people, there are very few medical schools around the world that actually engage in the sort of clinical research and the translational science that Mary's reporting, and that's wonderful for me. So, outreach. You've had a snippet of this already, but let me now introduce Dr. Elizabeth Grant, who's the Deputy Director of our Global Health Academy, and who's involved in some absolutely fascinating work of potentially great importance in Africa. Liz.
Thank you very much. No, let me just work. Great. I think, Mary, you set the scene wonderfully in with the extraordinary Edinburgh research that's going on. And one of the key messages, I think, of tonight is that we don't do research here just to get it into papers. Research is about making things better. It's about making a difference. It's change. And change so that patients improve, so that health outcomes globally improve. And I suppose all of us in our own personal journeys set out with a set of values and ethics. And the values and, I suppose, the ethos behind our primary palliative care research group, of which Scott Murray it leads and work on the international side of it, is around this sense that we're born equal, and we're born into and we die in really unequal circumstances. That's a message, in a sense, from Scotland, that we're born equal. That was Robbie Burns' message as well. But we cannot change the inevitability of death, but we can change these unequal circumstances. That's a message of the Enlightenment in Scotland. We can make a difference. And for us, so much is about what do we do with what we have, with the skills and knowledge, the ideas that we have in order to make this difference, in order to make changes. And this is a slide, you've probably seen it as well, we've used it a lot. No matter what WHO does, no matter how many what our NHS does, no matter what our global health world does, we're not going to change the fact that the world's death rate will remain at 100% mortality rate. 7 billion people in the world today, and they all will die. And actually, an awful lot more of them, we think, will need palliative care. Palliative care is not a niche subject. And many people have asked me, palliative care, why are you involved in palliative care in Africa? Africa, the continent that has such high maternal mortality, such high child mortality. Why are you working in this very small area? I feel it's not a small area. WHO, the World Health Assembly in 2005, committed and they said, this is an urgent humanitarian responsibility that we engage in supporting and building palliative care in a number of African countries. It's a basic human right that people can die in a way that is dignified, in a way that is as pain-free as possible. Yeah, palliative care is missing from the international agenda. And there's lots and lots of reasons for it. And sadly, it's also, it never appeared in the MDGs, which influenced and dominated the way development's gone. It's not going to appear in Sustainable Development Goals, which are the process that's going to come after 2015, that's being pushed at the minute by Jeffrey Sachs and folks, because palliative care is not seen really as a poverty alleviation measure. It doesn't contribute to an economically viable society. And yet, how can we all sit here? This for me, and it's the argument I have, an argument that our group has. Palliative care, palliative medicine is about humanity. It's about a care that means and will make the biggest difference in society. Just want to briefly say something about Sub-Saharan Africa. I know some of you, many of you actually have lots of knowledge and experience, much more than I probably, some of you. But Sub-Saharan Africa are a continent, 11% of the world's population, 24% of the global disease burden, and less than 1% of the global health expenditure. And strangely, and this is where we are only really beginning to recognise, it's also a continent where the diseases that we associate with African countries, those tropical diseases, diseases of HIV, diseases of TB, malaria, the neglected tropical diseases, are being merged into a whole new pandemic of non-communicable diseases. No one ever anticipated that. Everyone thought non-communicable diseases are the diseases of the luxury West, but they're not. They're diseases that are brought about by globalised forces, and now we know that so many of these forces are pushing the way in so many of our African countries. Many African colleagues talk to me about this double and triple, quadruple burden, a burden that probably is best actually captured in this spiral, in this vortex of systems playing off against each other. We've got this pandemic. And these are just some tiny illustrations. A random physician speaking to recently, he's making a comment, the economy in Sub-Saharan Africa is dependent on physical labour. So much of what people need to do is also physical labour, requiring a good heart. This was his comment. Heart failure is leading to deepening poverty. We're seeing huge amounts of heart failure. There's programs that the University of Edinburgh and NHS Lothian are involved in with the Cancer Disease Hospital in Zambia. And some of that programme is around looking at cervical cancer screening and cervical cancer treatment and follow-through of women with cervical cancer. And I'm just a little, 50 cases per 100,000 in Zambia compared to 7.2 in the UK. Huge disparity. With so little access to cancer screening, so little access to radiotherapy. And cancer's lying very, very much in the shadow of HIV in Africa, and yet 500,000 estimates of people dying with cancer, hardly any system in place to support that. This slide here is from Professor Jacobsen from South Africa, who spoke at a palliative conference 2 years ago, I think it was, now in Sub-Saharan Africa, looking at the number of countries which have adequate, or even coming towards adequate palliative care provision. It's quite frightening. There's huge. Sub-Saharan Africa, 800 million people, and this is the percentage where care is actually available. And even then, this has improved drastically since 2004, where there are so few. I think for us, the quality signature of a nation is how it manages birth and how it manages death. And what I want to do is just briefly talk to you about maternal health, which may seem odd, because WHO picked up that one of the big reasons for maternal mortality was around 3 delays. And they identified these very specific delays that if work could be done to change these delays, work could be done then to improve maternal health outcomes. Delay in decision to seek care, women not actually coming forward to get care, or the cultural situation, families not giving women permission to come forward, women having to wait till the husbands come back from the fields, women have to come back from the fields themselves before they're allowed to go to look for care, a delay in reaching the appropriate obstetric facility, and then when they got there, a delay in receiving appropriate care. I think there's 3 delays that are happening as well in palliative care in many African countries. And the reason I'm setting this scene is because I want to talk about some of the work that Edinburgh is doing and some of the works that folks like Mari are feeding into to really support a different way of working. these 3 delays in palliative care, and these delays have huge consequences. Firstly, a delay in knowing what's happening. In a number of the research studies that we have done, a theme that recurs again and again are, well, it's a common theme, a theme here as well, health staff who fear to tell the patient what's happening, what is wrong with them. So the message that they are living with a life-limiting illness is not given. And there's lots of reasons for that. And some are cultural, some are around skill base and knowledge, some are around, a number of nurses and doctors have said to me, it's difficult to give a message of death because that message may seem like you are cursing the patient. And it's difficult in this context to give that, what seems like a curse. I don't want to be a messenger of the curse. But patients then, not knowing what's happening, are constantly searching for cures and never finding them. And in a piece of research that I worked in when I was living in Kenya at Hospital, I was working along with Scott here, who was doing a similar piece of research looking at some of the palliative care needs that patients identified here in Lothian. This quotation came out again and again, this idea, searching for cures and never finding them. Families and patients' whole understanding of the illness often is based around an understanding of infection and infectious diseases, of cure and responsiveness. But actually think about our own understanding of our illness here and how so many of us don't want to hear words and don't want to break bad news and struggle also with actually understanding the nature of the disease. But it has massive repercussions. And this quotation, these 2 quotations, really capture the problem of not having an accurate diagnosis, of not being honest with the patient, of the patient not understanding that nothing they do, nothing they buy, no drugs will actually cure them. I spent over 1 million shillings on care as this person tried to find something for their nephew, sold what they had. You can see the cycles of poverty that happen. There's also fear among patients. And this was from quotations when we were doing an evaluation of the Ugandan palliative care programs. And one of the local chiefs talked about the fact that people fear to say the word cancer because there's no local word for it. And even old people and small children just believe cancer kills. So that cancer is not something that is supported, not something that's treated and provides supportive care for. Cancer, if you have that diagnosis, well, there's nothing you can do. That's the assumption. They think a patient will lose hope and die tomorrow. Patients go from one place to another, to charismatic sects, to healers, to losing their money. It happens again and again. A delay in receiving the right level of care. Mary mentioned this actually, and it's maybe one of the big reasons, in a sense, why a lot of the hospice work was done at the beginning. There's either 2 things quite often happen. There's very aggressive treatments. And again, these are aggressive treatments of patients who are in hospital, where the hospital has little money. There's few resources in the hospital. The patient has little money. The family has little money. And yet the treatment is on and on and on, as if somehow there's going to be this aggressive treatment will actually lead to a cure. Or the patient is left at the back of a ward, never seen. The patient's family is waiting for the doctor to come by week after week after week. And I'm not exaggerating, that may sound like an exaggeration. A number of my colleagues, my colleagues in Kenya and Zambia and Uganda and Malawi talk about this disparity, this shift, this change of what's happening between the 2. In the Malawi study at Kampala, Malawi is a national hospital linked to Makerere University, whom we work very closely with. The study just looked at all patients in the surgical and the medical wards, and 45% of admissions had life-limiting illnesses, yet under 5% were referred to the palliative care team, and this hospital does have a team because people didn't recognise. Because of lack of time, knowledge, skills of these busy practitioners, we can't judge so. These are people, our practitioners, the health professionals here, are working flat out. They're running wards, they're seeing numerous patients, the numbers of patients we're seeing are so much different from what we in the NHS may assume is a heavy day's load. People who are working in rural communities, constantly, never ending their work. But these are some of the reasons why that patients are not seen at the right time. And then there's this cycle of endemic system failures, and this from a consultant working in Malawi, and they're just listing the things, and even there's no paper for the clinical notes. You can see what's happening is systems coming apart, and the absence of pain relief. This quotation, I would like to go to sleep and wake up dead. It was with a woman I worked with when I was living in Kenya with breast cancer, and that was one of the really difficult things to hear someone say, to go to sleep and wake up dead. Because the pain was so severe, and there was nothing that this woman could have. The real needs, a key need, the need to come out constantly from our work of looking at how best to set up palliative care services was ensure that pain relief is available, ensure it's accessible, ensure we can get it into the system. We're a long way from the point where we'll have individual care, but hopefully the knowledge and experience that we have can be shared together, and the knowledge coming back this way as well, so that morphine can be. Often morphine is in the country, it's just it's not in the right place at the right time. We had a stock out in Uganda, had a massive stock out, no morphine available, but it was a systems failure. The money didn't transfer across. The vehicles weren't bringing the morphine. It wasn't that there wasn't morphine available. We could get it in powder, we could mix it in water. There's been such serious problems sometimes getting. And some of it's about regulation as well, and anxiety about who can hold morphine. Is it a dangerous drug? Often it's systems failures. But there's been some very innovative work done by colleagues of ours, and colleagues like Dr Dorothy Logie, who's one of Edinburgh's, linked to Edinburgh, looking at morphine and how to share. And the thirdly, this delay about getting to the right place to receive care. And there's one of the amazing things that's happened, and we have been involved in a little bit, is around the whole idea of hospice at home and looking at different ways of offering palliative care that doesn't involve being within the hospital setting. And yet there are times when the hospital setting is the right place to be. And some of the earlier studies we did, the patient said to us, if I'm at home, I remember one old man saying, I can control my farm with my mouth. I can tell others what to do, which was wonderful. I can see the animals, but actually my family feels sad because they can't do anything with my pain. They can't do anything with my sickness. Remember, so many homes in rural communities don't have running water, don't have an inside toilet. So if somebody's being constantly sick, if somebody's got constant diarrhea, if there's no sheets to change, it's very difficult. Others recognise that going home to the ancestral home is very important, going home to die, for the body to be buried, but sometimes that home doesn't have any access to treatment, so it's maybe better for people to stay nearer the cities until we can get the systems are in place. And a lack of support networks. What happens when you've got silo systems, and maybe this is one of the worst things that our whole development agenda has done, it's created these silo ways of managing disease. We've got HIV, we've got TB, malaria, hopefully not, it's going to happen with the NCDs are going to come in. Lots of money coming down one stream. Zambia at one stage had more money going into its HIV basket, as it were, than into the whole of the health system. How absurd is that? And yet that was what was happening because international donors were recognising that HIV was a massive problem, so therefore we'll put everything in. But what was happening also was health workers from other disciplines and specialties were moving into HIV work and counselling because that's where the money was. This development agenda that has done cuts and parts, that has really had a massive impact. And a lot of the work that we're learning from as well is how do we create and support developing new pathways of care that are continuous, that allow patients to come into hospital, to come through the hospital system, to get the care, to come back to their community, to be supported in that community, and then to be able to come back in if need be, or to have community practitioners go to their homes. That may have sounded very negative, and I think the most inspiring things for me, my real learning has come from so many of my African colleagues as well, about new and interesting ways of working. And there are a set of models of palliative care, and these models we're working with very closely, and I'll talk about a grant that we have in a few minutes. But models at the primary care level, models at the secondary care level, looking at the community-based care and regional district services, and models then in the main tertiary hospitals, looking at how best to engage to deliver care. And I'm just going to talk about a couple of different components of that care. Because total pain is still an issue, and it's so important to understand what lies behind pain, all of the issues behind how our body is managing pain, but also understanding how the different dimensions, those spiritual, emotional, social, economic dimensions, are impacting and influencing what happens. And some of the amazing care programs are around how staff have talked about the need and the importance of touching, of actually being with the patient. We instill a sense of hope before hope was lost in pain. Volunteering. It's not something we're pushing volunteering within our NHS, pushing it here in Scotland, but actually volunteering has been something that we can learn so much about, and I've met so many extraordinary volunteers within the clinical care programmes with which Edinburgh is attached to. Volunteers who have identified, who come from local communities, who feel that they want to increase their skill base, their knowledge, to care for their people in their local community. Volunteers who become the bridge between the hospital and the community. Volunteers who are the eyes and ears, who alert the nurses to come in, saying there's something, this person needs help. Volunteers who come in on a regular basis, a bit in the sense like what the home health service was, but actually, to be honest, a bit in the sense like what our communities maybe were 50, 60 years ago, where there was people coming together to really offer help and support. Supporting family care. And key for a lot of the work, and the work that we're involved in, is how do you ensure then, with the volunteers and with the family, that their expertise is increased adequately, increased enough, that they have the confidence to care. And there's this wonderful old woman up in Mau in Kenya who talked about how she said, I almost became a doctor. It's a wonderful part of that quotation, because she had received the training and the support from the clinicians in the hospital and the teams who were being trained across the board in order for her to actually do the essential care that she needed to enable her husband to stay at home. And he did. He stayed at home until he died. And a sense of recognising that there are times when we have to accept that death is a path we all tread, and there's no alternative. And there's times we have just being able to believe that, and not to stop the fighting against death, and to walk towards it knowing it's going to happen, but to walk towards death in dignity, so much that we can learn. But alongside the social support and the emotional support and touching and caring and supporting families, is this sense we know so many people are living in poverty. So many people have pain as a main problem, but actually alongside pain is, as this patient says, it's my house leaking, the bedding's not enough, I'm cold in the evening. In so many rural communities, in so many areas in urban cities, this is the day-to-day experience. Who'll feed my family when I'm gone? These are questions that we don't ask ourselves, because a system's taking care of that. How do you offer that practical sort of caring? And how do we ensure that patients can feel that they have what they need? And alongside that then, this third dimension, this clinical care, this clinical training, and as I said at the beginning, there's so little in the way of palliative care, and so few specialists. And I know we don't have huge numbers of specialists here in the UK, but there's a tremendous work that can be done, skill sharing and building up the knowledge base and particularly the clinical skills of health professionals who want to learn, who want to be part of palliative medicine which is a recognised speciality here in the UK, because that can make the biggest difference. And this, we're not talking about creating palliative consultants, we're talking about generalists, we're talking about people who have got who have got general practice and nursing expertise, actually learning these skills so they can make a difference, so they can become travel and bring the mobile clinical care. I want to just put this picture up, this series of pictures up. This is of a man called Samuel, and he did receive a lot of expert care. But before he received care, he'd actually had been told by those around him that the spot that you have, that what you have on your foot won't get better normally. It's not going to get better with the hospital. You need to go. And he described it, you need to go to a healer. So he went to a healer, and the healer put various plasters on it, various things, and it got worse and worse and worse. And then the healer felt that there was a curse in the man, so lots of money was spent trying to alleviate this curse. And then finally he got into a care treatment system. But he's so accepting, and I just wanted to put this up because Samuel, I thought this man is somebody who can give us hope. You can see how he was. His wife left him. He was left with a 5-year-old child who actually became his carer. The child made little bits of food, carried it to the man when he couldn't even get up out of his bed until the volunteers come in. And then the volunteers got the clinical team in, and the clinical team started to work. And they've been working with them. But he said, well, I'm here. I'm still here, and things are happening, and there's people engaged, and we're in it together. And clinical care in hospitals, sharing that specific knowledge. I want to have just a couple more minutes to make a few more comments. One around innovation in care and the knowledge that we have, particularly now around telemedicine, electronic health records and e-health. But to be honest, some of it's put me to shame, because you probably, if I use the word flashing, you probably think, we've got different ideas of flashing, but the flashing within this rural health context of clinical, of staff, actually meant where the volunteers picked up the telephone and flashed through a call to the nurse. They didn't let the number never was picked up, so it was a free call, flashed up the number, and then the nurse ran back to the volunteer, and through that communication network, it meant that volunteers didn't have to have loads of money on their phones. They could alert their hospital staff, their health staff. The health staff could get in touch, give advice, and you got this extraordinary system. The mobile phones being used in a really innovative way, not how I'm sure how Orange or Celtel imagined, a wonderful way where you thought that's actually about taking technology and making it work. And I mentioned we in the Edinburgh programme. We have got funding from the Tropical Health Education Trust and DFID for just under 1.6 million to look at how do we strengthen palliative care in the national health systems of 4 countries, and what's required. And the programme is looking at advocacy, actually ensure that within the national health systems, palliative care is embedded. And that's something we can do and can support the national palliative care associations in countries to do, because we also have gone through that journey ourselves. Part of the work's around doing training, increasing staff capacity in each of the countries, looking at timely service delivery, and then creating a supportive network. And just to show you how that's working, each of these 4 countries, some of them have more advanced palliative care than others, but none of them have a regional national palliative care system that works. We're working with 3 hospitals in each of the countries. We're working with them from the management right down to their satellite rural health posts. And alongside each of those country hospitals will have a UK hub here with practitioners who will link and support. The developing protocols, establishing those processes for referral, creating the pathways, building the procurement and prescribing systems, and supporting clinicians is what this grant will do. And it's what UK, Scottish clinicians, Scottish nurses, Scottish generalists, Scottish data managers, Scottish health service managers will work with our partners and to deliver that. So just in finishing, 3 lessons from Africa can change our practice here, I think. Communities do have extraordinary resilience, and sometimes we forget that. And we've seen extraordinary ways of working. The passing places between this world and the next are not as strong as we think. We often ignore them, and they are hidden, they're invisible, but they're there. Accepting death, that is a path we all must tread, is really important, and not seeing it as a failure. And this last point, which I think is actually the most extraordinary of all, is that the extraordinary things that are happening in many of our African countries with our African partners, with our colleagues, who using, just investing in change can make change. And sometimes we really forget how you can actually change a system if you believe that you can make it work, we can make it work better. That's the message that comes forward. Palliative care can be delivered in poverty, and it can and does by delivering it change poverty. I'm going to just finish now just telling you one little bit of a story, and it's a story of why I'm still involved in palliative care. And it was involved with a patient I worked with when we were in Kenya, and when I was involved with the study with Scott, and a patient who had she had cancer of the vulva. I'd seen her a few times, but we went up on that final visit. She asked the family, said, "Can you wash this patient?" And she was called Muka. She wanted to be washed. And we began to wash her, and as we washed her and lifted her, and she was given her some morphine, we realised that under her there was faeces, and in the faeces there was maggots, because the family no longer could lift her, no longer could manage. Her pain was so severe. She had bed sores that were huge and open. There was no sheets, there was nothing. And it was a very rural part in Mount Kenya. And I said to her, we have to take you to hospital. She said, "No, because I can't afford it." And we said, we'll cover that. Please, you know, there's no way we can manage these wounds here. And she said yes. And then again she sort of said no. And I said, "Why?" I said, "I can only go if you'll bring my body back to be buried in the land, in her shamba." And we promised we would. And this is her grave and her shamba in her garden. But that was one of the hardest things, because I thought, you know, here we are, 21st century, 20th century. This level of care, this shouldn't be happening. This woman shouldn't be dying this sort of pain. And we did bring her down in the car. And as she travelled in the car, she actually, as the morphine began to work a little bit, she rested, she became more restful, and then she started singing. And she was singing, "Trust in God in the journey, and stay together." And you thought, what an extraordinary message. Here she is, she's on a journey herself, she's on a journey to die. She knew she's dying. She's into the hospital. She's left everything. She's in this pain, and yet she still has a hope. And for her, and for, I suppose, so many clinicians and so many practitioners who work against the odds and make a difference, this is why, I suppose, my call as well is all of us can be engaged, all of us should be engaged. It's a humanitarian emergency, and a basic human right to offer folks. So I'm just putting this poem up, that'll be familiar to you. It's the last part of T.S. Eliot's Little Goody, his 4 quartets. And it's an extraordinary poem. Just towards the end, I've just picked a few lines. "We die with the dying, see they depart and we go with them. We're born with the dead, see they return and bring us with them. With the drawing of this love and the voice of this calling, we shall not cease from exploration, and the end of all our exploring will be to arrive where we started and know the place for the first time." I think that captures that we are in a cycle, we're in a journey, knowing the place for the first time and starting again. And he ends, "And all shall be well, and all manner of things shall be well." Thank you.
That was very moving indeed. I think we should have the chairs up and ask Mary and Scott to join you, because there's so many common themes here. Let's